Nick Majerison here. Welcome along to Top Med Talk. And it's time for a brand new series here on Top Med Talk. It's Tripom, trainees with an interest in perioperative medicine. They're reporting from the Ebpom Usa Dallas Master's Course, Perioperative Care Practicum, which happened, of course, in March of this year, March the 22nd to the 24th. Make sure you check out ebpom.org/meetings to find out more details of meetings that are being arranged around the world as part of evidence-based perioperative medicine. ebpom.org/meetings. In the meantime, let's have a listen to Tripom.
Top Med Talk.
This is Bridger Bach. We're here at Ebpom Dallas 2019, sitting down with a couple of interesting individuals. We'll introduce them shortly. I'm here with Robin Schiller.
Hello and greetings from Tripom, Ebpom 2019 Dallas.
And for those of you who don't know what Tripom is, it's trainees with an interest in perioperative medicine. We emphasize trainee involvement in perioperative medicine, but we are here with Drs. Attila Kett and Elizabeth Cherot. Could you take a moment to introduce yourselves?
Yes, I'm Attila Kett. I am the chair of anesthesiology at St. Peter's University Hospital. My background is in Europe. I did an OB residency before, and now I'm very invested and very interested in obstetric anesthesia. And part of that, we introduced the first obstetric ERAS program in the United States.
I'm Elizabeth Cherot. I'm the Vice President of Medical Affairs for Axia Women's Health. Axia Women's Health is one of the largest private OBGYN groups in the country. We're focused out of New Jersey and Pennsylvania. My particular care center where I actually deliver babies and have delivered Dr. Kett's babies is in New Brunswick at St. Peter's Hospital, which is where the two of us have known each other for years, and starting in 2016 had the opportunity to really embark on this together.
Fantastic. And I think the work you guys are doing is excellent. It's groundbreaking. For people who weren't able to tune into your talk, could you just give us a little bit of a background about why you even decided to come up with OB-ERAS and what patients are included in that?
Yes, so our hospital is a large perinatal center. We deliver about 6,000 babies there. So it was kind of a no-brainer that this is the area where we can make the biggest impact. Besides that, even countrywide, obstetric patients are the biggest bed users, so this is certainly a huge opportunity. You also have to look at that whenever you give birth, we talk about two patients, the mom and the baby, so the impact is even bigger than that. That was certainly one important consideration, and also other things are important when you start an ERAS program, and especially when you start your first ERAS programs. I think it's extremely important to work with someone who you can work well. I mean, a surgical champion and an anesthesia champion. And that our friendship really helped to facilitate that. So these were the important points. We started our program in 2016. At that time, we were the first. By now, there are a couple of programs around the country. And by now, we had well over 500 patients finish this program.
Well, that's absolutely tremendous. 500 patients, started up in 2016. You've made tremendous headway since then. That's just fantastic. Your ERAS pathway that you guys have developed, could you touch on some of the real important aspects of that maybe some trainees or other people listening in to our audience here can start implementing or start thinking about incorporating in their practice that you find to be very beneficial with outcomes?
The most important thing is patient engagement, empowerment early enough. So we actually use a smartphone application which we developed right now. We are on the second version of that, and it is extremely helpful. Educate them so you control the information, what they are getting. They're getting the right information. They're not just Googling something which is correct or not. So that's probably an extremely important point. Same tool can be used to measure compliance, which we know if in an ERAS pathway your compliance rate is below 70-80%, that's not good. So we can act on it quickly if our compliance drops. one area or another. And third, it is extremely helpful to monitor patients postoperatively. If you discharge patient early, you still want to keep an eye on them and want to ensure them that they're not just lost in this big postoperative black hole, but we actually know what's happening with them, and if anything goes wrong, we can intervene quickly.
And who gets that information from the application that the patients download? Like, who processes that information and follows up on it?
So when patients come in for their 36-week obstetrical appointment, usually you're talking about your surgical date about 3 weeks away. So we're doing scheduled repeat C-sections at 39 weeks, which according to the American College of OBGYN is standard. So they download their app at 36 weeks. They are pushed videos, they're pushed information just on what's going to happen during the surgery, pre, post, and even intra-op. And there's a consent form that's done. So it's all HIPAA compliant. But we drove that information, as Attila mentioned. We wanted to control it, but really you want to make sure you're messaging the same thing. If you look at patient satisfaction data for maternity care, it's all about driving the same message and actually having consistent care while they're in the OR and postoperatively. So their expectations are then met. There's that sense of autonomy, that sense of control, but they understand that they're going to get their catheter out in 12 hours and actually walk and get up to go to the bathroom, that they can eat in the recovery room. They can start by chewing gum and eating right away. We're not serving them French fries, but they can start, sipping on juice and water, and that we're actually going to let them drink up until 2 hours before their surgery. They can have water, and they're going to get a perioperative drink. So understanding all of that, when maybe they've had a C-section before, that is not their experience before. We actually put babies on the chest, right? So remember, we're having surgery, but we're actually having a baby. So it's not your typical, as you've been listening to ERAS here and cardiac surgery and colorectal. There are two patients, and there's an outcome here that I wanted patients to have the same experience as a vaginal delivery, which seems like the norm. So can we normalize a surgery? Sounds a little crazy and quirky and maybe even cheesy, but it is what women want or want to have. So that was the process that we sort of looked at. We kept them warm in the OR on a warmer. We've given them warmed IV fluids, and some of those things, some of those tricks, or nuts and bolts that we'll talk about tomorrow in our program, really were things that physiologically made sense that I'm not sure why we weren't doing before. Now we look back and think like, what? But and patients who are now, we're in our first iteration of our ERAS program, are actually having their second child in the ERAS program. So it's really interesting to see their outcomes and their excitement for the program. And patients who come in who have downloaded, who've seen the next iteration of the app, are super excited about it. But we have a nurse, which is probably what I should have spoke to, who actually logs in and checks our dashboard on a daily basis. There are alerts that patients get to say, ooh, call your doctor, and whether that's that DVT symptom or email your incision, picture for us to look at, which sounds gross, but it's actually very reassuring for a patient to have, and they feel connected, especially if they're going home on day 1 or day 2 from their surgery. So it's a really interactive, really actionable, as we've talked about, but it hits everything from breastfeeding to mood to your incision to mobilization, just really the pillars of ERAS programs.
That's fantastic. So what have you guys seen? I know you're going to touch more about this tomorrow and so forth, but for some of listeners who aren't with us today, what are some of the big outcomes that you've seen, specifically with mom? And then have you noticed any outcomes on the infant or the child going forward with this implementation?
So probably the most frequently quoted outcome measure in ERAS programs is length of stay. And my morning talk, I mentioned that in the UK, they call this next day discharge, which, really raise eyebrows here. But the fact is that the average length of stay in this country is about 3.6 days. And we were able to reduce it in the low 2s, which is really, really important. At the same time, our patients, we have the tool now to really reliably measure patient experience, patient satisfaction data. So our patients become happier, which is extremely important. Our readmission rate didn't increase at all. It's
rather drop,
yeah, it's rather dropped. Probably it's below 2%. So these are really the most important.
You forgot the opioids.
Oh yeah.
Like, come on. And actually, it's funny you didn't mention it, because I think the two of us back in 2016 really looked at reducing stay, better outcome, and at the time, I would say the opioid crisis was just really coming about, and really we were in New Jersey sort of mandated to go through, some training, but also sort of talking about what prescriptions we're actually writing. And an average New Jersey was writing for 40 Percocets, oxycodones to go home with which was just sort of routine. And we talked about that here today, or at least in ERAS discussion at Ebpom here the last 2 days. But I'll let you talk about our outcome.
Yeah, so
I didn't want to steal his thunder.
It is actually very surprising. It's a recent study from Duke that after C-sections, it is the third highest number of pills what patients go home. The first two are not surprising, right? It's joints and backs. But C-sections, really, we send home patients with that many pills. So that's number one. Number two, another important paper from Brian Bateman, that patients who go home with these pills only use a portion of these pills, less than half of the pills. So those pills get on the medicine cabinet, and it's ready for either way use later when you have a benign injury and get hooked on it, or could be picked up by housekeeper, could be picked up by kids, anyone else. So step number one for us was how we can reduce opioid usage is in the hospital, while you make the patient still happy and comfortable. And we have a protocol when we use non-steroidals and Tylenol in scheduled intervals. And we added long-acting local anesthetics first in a surgical infiltration technique. Liz can talk to that more. It's a multi-layer infiltration technique. And now we also had a study which will be presented and published at the SOAP meeting, which is tab blocks. I can't really say again before SOAP that the exact results of this, but it's actually stunningly similar. Number one, that the surgical infiltration and tab blocks work approximately the same way and the same level. And it's also stunning that from the 60 morphine milliequivalent what we used before, we went with the non-steroidals and Tylenol to 30, and again when we added the local anesthetic, we halved that, so down with 15. So these are the results in the hospital. However, this begs for the question, what do you do with this information? Great. We use only that much, but are you going to still send a person home with 20 or 40 or whatever number of pills or not? So one approach would be to say blanketly, like we heard yesterday in Michigan, reduce this to 15. Or the other approach, what we are doing, is looking at it and say, hey, can we individualize it? 60% of our patients use no opioids in the hospital, so don't send them home on opioids. But have a discussion with them, and we have a tool in our app to do that. And the rest of the patients go home but with less pills based on their opioid usage 24-hour period prior to discharge. So that's what is our benchmark. And we are pretty successful with this. We follow up the patients afterwards. We have that tool to really remotely monitor them. And that leads either way supplemental prescription if needed, or alerts how to dispose it properly.
Interesting. I mean, it's tremendous work and great success with the opioid reduction. It begs the question, moving forward, can we get away from opioids altogether on these procedures and go to like maybe even QLs, ES blocks, some sort of more regional technique that we use in bariatrics, or not really bariatrics, but in colorectal surgeries or abdominal surgeries, and move away from that?
Yes, there is a study actually being designed, and we're going to get started with it pretty soon. It's going to be called the CHOICE study, where we are going to try to do that.
Fantastic.
Question is, obviously the gold standard in obstetric anesthesia is neuroaxial opioids. It's a very, very tiny dose. There is some push to reduce that to almost zero. I'm not sure I completely agree with that, but certainly I think there is an opportunity there to reduce from the commonly used 150 microgram, what we're using now, 100, to down potentially to 50, and eliminate IV opioids. So yes, I think it is possible.
That's fantastic. Wow. Well, I guess more to come and more to look forward to. Thank you both.
Thanks for having us.
We really appreciate it.
Thank you.
Appreciate it.
Top Med Talk.
Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about Ebpom London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that Ebpom organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.